Good morning, everyone, and a very good evening to Dr. Duda in Boston, USA, and other delegates who may have joined in different parts of the world online. Appropriate greeting to them. Welcome to the fourth edition of the Jaipur Surgical Festival, which is an academic activity that we started here at the Mahatma Gandhi Medical College and Hospital, which is a unit of the Mahatma Gandhi University of Medical Sciences and Technology in Jaipur, in the state of Rajasthan, in India. Just a brief overview of our institution. We are the first private medical university in the state of Rajasthan. Uh, we have 8 constituent colleges, including medical college, dental, nursing, occupational therapy, physiotherapy, hospital administration, health informatics, and various other allied health sciences. And in the next few years, which includes our Silver Jubilee year next year, we plan to introduce a faculty of management sciences also. The medical college offers courses uh, at various levels, including graduate, postgraduate, and super specialty courses, which are equivalent to the fellowship programs in the US. In almost all specialties, subspecialties, and super specialties, which are identified in the list of the National Medical Commission, which was erstwhile called the Medical Council of India. The fourth edition of the Jaipur Surgical Festival theme is complications in surgery. We thought that it is our duty and responsibility to cover this topic because unfortunately this topic is not covered or not paid so much attention in the usual meetings and conferences because people are reluctant to talk about their complications. But we know that whenever we do a procedure or an operation, complications are going to occur. They do occur and they will continue to occur. So it's very important for our young colleagues, the students and the young practicing surgeons to know about them and to know as to how to manage them. The previous three Jaipur surgical festivals, the themes were safe cholecystectomy, hepatopancreatobiliary oncology, and we also did a close group meeting, international study group on gallbladder cancer, emphasizing the problem of incidental gallbladder cancer. And I'm happy to inform that 3 or 4 of the subgroups of the last year's meeting, they have completed their manuscripts of the reviews on the topics allotted to them. And these manuscripts are under the process of submission to various journals for publication. In addition, we also did a IASCO postgraduate course on jaundice. And I am happy to inform that all these academic activities have been held under the auspices of and have been endorsed by the International Association of Surgeons, Gastroenterologists, and Oncologists, IASCO. And as you can see, Dr. Duda, who is the honorary secretary of IASGO has joined us from Boston online. Dr. Duda is a radiation oncologist who is also involved in a lot of translational research. And as I mentioned, he holds the position of the secretary of the IASGO. And once I finish the introduction, we would have him say a few words about our collaboration. In addition to Jaipur Surgical Festival, actually Jaipur Surgical Festival is an offshoot of Jaipur Surgical Tutorial, which is an online education portal that we started more than 3.5 years ago, and which is being managed by my colleague, Dr. Anand Nagar, who's with me as professor of HPV surgery and liver transplant. And under the auspices of the Jaipur Surgical Tutorial, we conduct an online teaching class every Saturday, 9 to 10 a.m. India time. And I am happy to inform that we now have almost 1,000 members, students and faculty, including about 200 from outside India, uh, who attend and then watch these activities online. As an extension of the Jaipur Surgical Tutorial, we also organize a monthly, once in a month, masterclass on a single theme topic. 16 such masterclasses have been held in the last almost 1.5 years. This is done every Wednesday and Thursday of the month, 7 to 9 p.m. India time, 2 hours on Wednesday and 2 hours on Thursday. The next masterclass at the end of this month is on corrosive esophageal injury. We are going to announce it soon. In addition, Anand also helps me in conducting what we call a Jaipur cholecystectomy coaching, where we contact a surgeon from whom we have recently received a referral for post cholecystectomy bile duct injury. And we request them to participate in a one-to-one session with us, me and Anand, where we discuss that particular case and their past experience with lap chole and try to kind of educate the surgeon as to why this injury occurred, how he or she can avoid it in future. And as a gesture of their participation in this interview, which of course is a pure academic exercise, the data is entirely anonymized and confidential. We send a copy, complimentary copy of my book, Safe Cholecystectomy A to Z, to the surgeon. Uh, we also do offer in a service called Jaipur Paper Clinic, where I encourage young students and young surgeons that if they are writing any abstract or a manuscript, they can send it to us. I try my best to polish it as much as I can before they submit it to a journal for publication. As a educational activity for the lay public, we conduct what we call a Jaipur Swasthya Charcha. It means the Jaipur Health Discussion, where we go to any school, college, university, organization, or department, and we discuss a topic which they want us to discuss. I take a panel of experts related to that topic, and in an about an hour session, uh, we discuss the public health related aspects of that topic. We've already conducted more than 50 such sessions in the last 1.5 years. We also propose to start an activity called Jaipur Surgical Gurukul. This has been in my mind for quite some time, but for various reasons I have not been able to start it, but hopefully next year. We would invite students, especially those who are going to appear in the final exam, and more so those who have failed in one or more attempts, and give them intensive coaching to prepare them for their exit exam, when they stay with us, say for a few days or a couple of days. And I am happy to see my colleague, Dr. Raj Govind Sharma, who is the Chief of Surgical Oncology, in the audience. They have been doing this activity for last almost 2 years, which is very popular. Uh, a large number of students from the state and adjacent states come and attend this activity. I have to add that although the Jaipur Surgical Festival is organized by the Center for Digestive Sciences at my institution, this center includes all four departments: medical gastroenterology, surgical gastroenterology, hepatology, and HPB surgery, and a liver transplant unit. In fact, we are a unique institution in India where in the same institution, all four departments exist as independent units, and we offer fellowship training program in all these four specialities. So while the academic activity is conducted by the Center for Digestive Sciences, the technical support is provided by Gastro University, which is an online portal run by my former fellow from Lucknow and now a consultant GI surgeon in the city of Ahmedabad, and his technical team, Dr. Avinash Tak. His technical team offers all the technical assistance. Just a word that the faculty of the JSF may feel that the audience in terms of delegates is limited, but I have seen that that is the usual trend these days in most meetings and conferences. In fact, even in JST or the master class, we find that the students who are joining live, the number is small, 15, 20, 30. But next morning, when I look at the YouTube channel of Gastro University and our university, I find that hundreds of students have viewed the video overnight. So probably that is the trend. The students these days don't want to be bound down by us as far as time and venue is concerned. They want to watch and learn at their own convenience, at their own pace, at their own time. So I'm quite happy about it. I request all my faculty colleagues not to get disheartened by the small attendance. Your efforts, your time is valuable, and I can tell you that it is being valued by students even now. Almost 10, 15 minutes ago, I received a lot of messages from GST students that they have logged in and they're waiting for the proceedings to start. So whether they are in front of us or whether they are remote from us, I assure you that your efforts, your time is not going waste. And in fact, I just looked at the Gastro University YouTube channel. The first JSF, the maximum number of views that we have had so far is almost 3,000. And all the master classes, the number of views range from a few hundred to even more than 1,000. So with that in mind, I am going to announce that the fifth Jaipur Surgical Festival probably would be a pure online mode, but we request the faculty to come to Jaipur so that you can interact with each other, with us, see the city. So we will be here, we will interact with each other, we will generate the discussion, but I think the delegates, the students would be online, whether they want to watch it at that time or later. So we will probably change depending on how the world of teaching and education is changing. So with that, I would like to thank everyone. We have faculty colleagues from Nepal, we have a colleague from Japan, we have a colleague from Bangladesh, we have delegates from Tanzania, Cambodia, and uh, one or two foreign faculty and delegates just last night, they informed me that they are not able to come. We will have a few delegates from India also. But as I said, that the total number of delegates, including online delegates, would be much more than this. So with that, I would now invite Dr. Duda, who, as I mentioned, is a radiation oncologist, but also a translational scientist. And he's with us today for us in the morning and for him in the late evening because he's based at Boston, the Harvard Medical School and Mass General Hospital, and he holds the position of the honorary secretary of the International Association of Surgeons, Gastroenterologists, and Oncologists. Welcome, Dr. Duda, please.
Yes, good morning. Good morning. Good morning, everybody. On behalf of the International Association of Surgeons, Gastroenterologists, and Oncologists, IASGO, on behalf of President Mohammed Abdel Wahab, of my co-secretary general, Professor Kyoichi Takaori, we're really delighted to welcome you to the fourth Jaipur Surgical Festival, which is being organized, as you heard, by the Mahatma Gandhi Medical College and Hospital this next 3 days. I greatly enjoyed myself participating in the past meetings, and I really regret not being there with you, but I'm sure this year's meeting will be equally exciting and successful. A few words about IASGO. IASGO was founded in Amsterdam and the Netherlands in 1988 and is really a unique multidisciplinary society with the aim of globalization of the best medical knowledge and practices. IASGO encourages surgeons, gastroenterologists, and oncologists to join forces to realize the mission of IASGO worldwide. Millions of people worldwide die from treatable conditions due to lack of routine surgeries and care. Moreover, the major breakthroughs that have transformed medicine over the last decades do not reach sometimes the patients at a global scale, in part because of lack of knowledge. So IASGO's vision is that up-to-date medical knowledge and expertise could and should benefit all communities globally. It has to be available beyond any discrimination based on individual, institutional, and national level to every patient who strives for survival because of challenging and life-threatening diseases. The mission of IASGO is to provide excellence in patient care by administering the highest quality of service in a safe and compassionate environment. IASGO leadership strives to implement this vision through a well-structured educational program with a global reach. We're teaching and promoting multidisciplinary collaborative approaches for treating these very difficult to treat diseases. This year, we actually celebrated our 35th annual World Congress in Cairo, Egypt, and we also held over a dozen CME symposia with large participation worldwide, and we're, of course, very happy to be back in India. In addition to communicating the latest clinical and scientific developments, friendship and collaboration are also vital in carrying out the mission of IASGO, which is globalization of medical knowledge. This fourth annual JSF meeting is another excellent opportunity to meet old friends and make new friends. We commend the remarkable efforts of Professor Kapoor, who has spearheaded the efforts to implement the IASGO programs in India, as you've just heard. Along with a dedicated organizing committee and strong institutional support, he created one of the highest level programs, including international experts from Asia and all over the world, and also promising young fellows. This will lead to networking and cross fertilization among experts at various stages of their career and diverse interests to promote further collaborative projects at an international level. Professor Kapoor has actively involved in IASGO for more than a decade, including participating at IASGO World Congresses in Bucharest, Vienna, Fuzhou, Seoul, Moscow, Taipei, Istanbul, and Verona, as well as multiple symposia such as those in Beijing, Belgrade, Cairo, and Chiang Mai. Before that, he was the guest editor of the special topic on gallbladder cancer in the IASGO official journal in 1999, which included experts from all over the world. He also organized an IASGO course, as you just heard, on jaundice in March of last year, which was attended by our past president, Professor Ender Dulundu. Finally, Mahatma Gandhi Medical College and Hospital Jaipur launched, as you heard, the International Study Group of Gallbladder Cancer, ISCJBC, on the lines of the International Study Group of Liver Surgery, International Study Group of Pancreatic Surgery, and International Group of Rectal Cancer. The aim of this effort was to produce a series of consensus statements on various aspects related to gallbladder cancer. And of course, given its relevance and implications, IASCO has fully endorsed this effort of the ISGBC. And I'm really delighted to hear that 3 of the manuscripts are already prepared for submission, and want to congratulate all the people who have been involved in this wonderful effort. This year's JSF theme is the complication in surgery. Most sessions are related to surgery, gastroenterology, and oncology, and feature key local and international experts. We are delighted to endorse this symposium, which is becoming a wonderful tradition for Indian experts and the ISGO. I would like to end by welcoming you again on behalf of the ISGO to this meeting in Jaipur, a celebration of the latest medical and scientific advancements in gastroenterology, oncology, and new treatments. Thank you very much for your attention. I wish you all a productive and enjoyable meeting, and look forward to seeing you next year.
Thank you, Dr. Duda. That was Dr. Duda, the Honorary Secretary of the International Association of Surgeons, Gastroenterologists, and Oncologists, joining us from Boston in US, although it's a very late evening for him. Thank you, Dr. Duda. I'm also happy to see Dr. V. Sitaram, one of the senior most GI and HPB surgeons of the country. Actually, we wanted to invite and honor him at this meeting, but because of some personal and family reasons, he was not able to travel, but he said that he will join online. I am happy to see Dr. Sitaram. Thank you very much for joining. In fact, Dr. S.K. Mathur, another very senior surgeon, he also said that he will be joining online, and probably Dr. Shastri also will join. I request all these senior members to please contribute to the discussion, because most of the sessions are in the form of panel discussion rather than didactic presentations. So I request Dr. Sitaram and other senior colleagues who would be joining online to please chip in and offer your valuable experience and wisdom to the young participants of this meeting. So with that, we would start with the scientific program. Rajiv, you are going to? Yeah. So my fellow, Dr. Rajiv Patil, he will conduct this scientific program. Thank you all.
Good morning, everyone. A warm welcome to 4th JSF, Jaipur Surgical Festival. And we'll begin our session with the first topic on definition and classification of complications. And do complications affect in long-term survival? I'll be calling upon Dr. R.P. Choubey, former professor and head of the Department of Surgical Gastroenterology at Mahatma Gandhi University of Medical Science and Technology, Jaipur, and to chair the session. And with him, I'll be calling upon Dr. J.M. Mehta, senior consultant in surgery in Narayana Hospital, Jaipur. And for the discussion, I call upon Dr. Rajiv Panwar, Associate Professor of GI Surgery and Liver Transplantation, AIMS New Delhi, and Dr. Avinash Tank, Senior Consultant Gastroenterologist at Apollo Hospital and the Dwarika Hospital from Ahmedabad.
Good morning, ladies and gentlemen. It gives me immense pleasure to start the scientific proceedings of this fourth JSF. My colleague, Professor Mehta, not being able to be physically here because of some reasons, but I can see a lot of my old friends. Bhatta is here, TD is here. Without wasting any further time, I start this session and request Dr. Rajesh Panwar to come and deliver his talk. Dr. Rajesh and me, we share the alma mater. He is assistant professor in surgical gastroenterology. I'm not sure, assistant now associate professor of surgical gastroenterology at All India Institute of Medical Sciences, New Delhi, where I was trained way back in 90 to 92. So I request now Dr. Rajesh.
First of all, I would like to thank the organizing team, and especially Professor V.K. Kapoor, for inviting me to this talk. Theme of this JSF is complications, and as Dr. Kapoor pointed out, this is one topic which is often neglected in usual conferences. And this also is a topic which is close to my heart. I have done some work in this regards. So I hope I would be able to do justice in the next 15 minutes. For my talk today is definition and classification of complications. Let's start with the usual surgical audit of an institute. There are two different surgical units. Surgical unit A both did around 1,500 cases in the year. The unit A reported a mortality of 5% and complication rate of 40%, while the unit B reported mortality rate of 5% and complication rate of 70%. So who do you think performed better? It seems like that unit A performed better because it had a lower complication rate. But are the two audits comparable? We don't know how they defined the complications. So it is important to define the complication. You came out with a number, but how do you know that number is comparable to some other number which some other person is quoting? Why do you need to define? Because if you define a complication, you are likely to pick it up early, and that will increase the patient safety. It also helps in training and education of the surgical residents, because if they are able to identify complication early, then obviously they learn how to manage those complications. And it is an important outcome measure for research, because if you want to do comparative analysis, then you have to, and it's an important outcome measure for research, because whenever you want to compare, you have to have identical definition. It is an important benchmark, because something that if you achieve a complication rate of 10%, that is the benchmark you want to achieve. And that can only be defined when you have a proper definition of a complication. And then your own quality improvement. You want to improve from year to year. Last year, say your complication rate was 30%. Next year, it is 20%. So you're improving day by day. And you have to have a measure to know that. You have to measure complications effectively to achieve that. So what is the definition of a complication? It can be simply defined as any undesirable, unintended, and preventable outcome of a surgery which negatively affects the patient's health. In other words, you can simply state that any deviation from a normal postoperative course is a complication. Now, some people differ in what complication means. Some people say that it is only the technical part of the surgery which leads to complication. Then only it should be called complication. However, for all practical purposes, any post-operative outcome, whether it is related to surgical technique, whether it is related to the patient, anesthesia, or any other factor, it should be termed as complication. So no matter what, if a patient developed stroke in the post-operative period, even though the patient had the risk factors, but if it develops after your surgery, then it will be called a surgical complication. But it is easier to define a complication if you can define a normal postoperative course. A normal postoperative course for me, for a patient of Whipple's, would be say that I want to discharge the patient in, say, 10 days. And the person says that if the patient is not discharged by day 7, it is not normal postoperative course. So people may have a different definition for a normal postoperative course. Once you have a definition of normal postoperative course, you can easily define a complication, because any deviation from that course will be a complication. But is definition enough? So you say the complications has occurred and you have defined. So the same example, now both the units are using the same definition. They are defining any deviation from the normal postoperative course, and they have defined the normal postoperative course as well. And now unit A has a 60% complication and unit B has a 70% complication. Now can we say that unit A is better? Does severity of complication matter? Mild versus moderate versus severe? Does timing intraoperatively, early postoperative, 30-day, 90-day, late? Cause of complication will not matter that much further, but obviously for classifying it may matter. So complications can be further classified based on their severity, timing, system affected, and cause. So all these factors may be used to classify. So now we come again, go back to the audit. Now they have ticked all the boxes. They have defined the complications. So in unit A, there were 20% mild, 20% moderate, and 20% severe. And in unit B, there were 50% mild, 15% moderate, 5% severe. Now we can say that unit B performed better than unit A, even though the complication rate was higher in unit B as compared to unit A. Now we have reached somewhere. So we have understood that a standard classification system is required if you want to compare outcomes. So are there any standard classification systems? First of all, these are the attributes. It should be simple. So if you give a complex system to people, they are unlikely to adopt. It has to be simple. It has to be objective. What I measure, the other person also should be able to measure the same. If I say it is a severe complication, other person should be able to say that it is a severe complication. And incidence has to be measured. So you have to count the percentage of the complication in a group of patients. Severity has to be assessed. So it is not enough that complication has occurred. You have to tell whether it is a mild, moderate, or a severe complication. And ultimately, if it is possible, you should be able to assign a score to a complication. Like you can say, out of 100, this patient had 30 complication or morbidity. 30 is the score that that patient got. So this, whether we have achieved that level, we'll see later. There are already some standard classification systems. The most commonly used Clavin-Dindo, we'll see all them in detail. And all of first two are based on mild, moderate, severe. Next two, comprehensive complication index, and these are scoring systems. All these are based on the one seminal paper that we'll report later. And there are some standardized definitions of specific complications. Suppose you want to measure a specific complication, you want to decrease postoperative pancreatic fistula rate. How to do that? For that, you have to define what is postoperative pancreatic fistula. So there can be separate definitions for postoperative complications, and those can be compared. So this was a seminal paper. Both Clavian and Strasberg were a part of it. They defined, gave a T92 system of classification. Previously also people try to define, but this was the one paper that forms the basis of all further classifications. So they defined mild, moderate, severe, and they defined on the basis of how you are going to treat the complication. If your complication is self-treated, that you don't require any treatment, then it is mild. If it requires some management in the form of medicines, then it is moderate. And if it requires invasive procedure, it will be a severe complication. Grade 4 will be death. So this was the initial paper. And based on this, the landmark publication from Clavian in 2004 Annals of Surgery, they further refined this and put forth the currently most commonly used system, the Clavian-Dindo classification. So it was developed initially in 92 and then modified in 2004. The purpose was to standardize the assessment and reporting of postoperative complications, and it will facilitate comparison across the studies, and grading is based on type of intervention. So this is the original classification. I'll make it simple for you. So grade 1 is when it is self-limiting complication, no treatment is required. Grade 2 is when only medicines or pharmacological treatment is required. Grade 3A, if a procedure which can be done under local anesthesia. Grade 3B, if procedure under general anesthesia. Grade 4A is single organ failure. Grade 4B is multi-organ failure. And finally, grade 5 is death. So this is a simple ordinal scale which can be used to classify complications, and it has been extensively used. This paper has been cited more than 3,000 times. Based on the T92, Strasberg also was part of T92 classification. So he gave his own version of classification called the accordion classification. So This essentially is almost similar, but not much used. It has two forms: contracted forms, which has only 4 parts, and then the expanded form, which has 6 parts. It is more or less similar to what proposed by the Cleveland-Indo classification. So then the definition of individual complications, like International Study Group of Pancreatic Surgery, they have defined pancreatic fistula, delayed gastric emptying, and post-pancreatic hemorrhage all have been defined. So these are the standard definitions. You can define for every study, whatever the most common complication of that surgery is, you can define that complication and use it to compare. Now, if you see papers on delayed gastric emptying, you can find 100 different classifications of delayed gastric emptying. So if you have so many classifications, you cannot compare one study to the other. So for example, somebody defines delayed gastric emptying as if NG is there on the day 4, it will be DG. So incidence will be high. So in thus such studies, the incidence reported will be more than 50%. But in Japan and in Eastern countries, initially DG definition was that patient should be able to tolerate a porridge-based diet up on day 30. So that was the definition of delayed gastric emptying used some time back. Now everybody uses the standard definition. So in that, the incidence will be 10%. So you're talking about the same thing, but incidence will vary from 10% to 50%. So you cannot compare studies. Similarly, there is an international study group of liver surgery, which defines a post-operative liver failure. But it's still something is still missing. We have achieved something, but let's see a patient who develops 2 grade 1 complications, 2 grade 2 complications, and 1 grade 3 complication. The final score is a grade 3 complication. Another patient develops only 1 grade 3 complication. He also gets a grade 3A because Cleveland-Indo only considers the grade of the most severe complication. So obviously in this scenario, you are ignoring the 4 other complications that this patient suffered. So still we are far from perfection. So how to account for multiple complications? So this was a paper which came in 2013 by the Clevin group. They uh, introduced a comprehensive complication index. I'll subsequently tell you in some details. And then we developed our own complication severity score, which was on similar lines but had some basic differences. So that was CCI, and we gave a CSS. So what does these complication score do? So they account for each and every complication. Minor complication will have less weightage, and weightage will increase as the severity increases. And then you add the weightage of all the complications and take a square root. That gives you the final number. And death is assigned a score of 100. So this is the relative weights. So you give a weight of, say, in CCI, grade 1 gets a weight of 75, then increasing weight, and then you add all the weights of all the complications, take a square root, you get a final complication number. So don't get confused. You can find this in the paper, and it can be done on an app based. So you don't have to calculate yourself. You can just feed the data in the app, you can get the answer. So the same patient who developed 2 grade 1 complications, 2 grade 2 complications, and 1 grade 3 complications, you'll add the weightage of all these complications, take a square root. For CCI, you'll get 41.4. For CSS, you get 9.9. So this is the final. You can measure the morbidity on a scale. So that is what the output of these complication scores is. And this can be treated as a number and can be compared, mean can be calculated, standard deviation can be calculated, and then you can do comparison across the studies. The advantage is that it takes into account all the complications. A numerical best value is assigned. You can calculate mean standard deviation, and by doing that, you may actually reduce the required sample size of the trials. But there are some disadvantages also. It makes data collection cumbersome. So you have to keep a watch daily if a patient, note each and every complication that a patient develops. In the other scenario, you only had to bother about the most severe complication. Here you have to take into account each and every complication. Weights defined in the studies, there are some logic to that, but they are not 100% because we don't have any gold standard to compare with. So if you don't have a gold standard to compare with, these weights are, all these weights are actually assumptions. So you don't have nothing concrete in your mind, and you are basing on some logic, but you don't know whether it is true or not. And you don't account for within groups. So 3A complication can be a simple one-time aspiration of a pleural effusion, while it may be a pictorial drainage of a liver abscess, are both same. So in the groups, they're both 3A, but there is difference. Duration of complication not accounted for, and it is difficult to validate as there is no available gold standard. Sometimes it may be too sensitive. The difference that it detects may be too small clinically. So if somebody has a complications rate of say 38, somebody has 40, is 40 actually more than 38? Nobody knows that. So in summary, standardization, the standard definition of complications is very paramount, as we have seen. Clavin-Lindo is the most commonly used classifications. Complication scores may be a step better, but still they require a lot of refinement and validation. Thanks for your patient here.
Good morning, Chairman, Professor P.K. Kapoor, sir. And thank you for giving me an opportunity to present the topic on this platform. And my talk is made easier by the previous speaker. In the same continuation, I will discuss the do complication affect the long-term survival. I got Kapoor sir shared this topic so less to make. Do you like to do that? I find this topic a little bit unusual. I thought does it really it makes a difference in outcome? My first response was no, it does not make usually enough for at least for benign diseases. In malignancy, it may yes. So I discussed with my colleague also, putting same question. What do you think so? Does complication makes a difference in long-term survival? And with their anecdotal personal experience, they said no, it does not make. But I thought if Kapoor sir has gone through this topic, let me see, dive into the literature, what does literature say? And the results are really remarkable, eye-opening for all of us. So I will discuss this topic in detail. So post-op complication has been associated with a decreased long-term survival. It means it is already proven in a cardiac surgery, orthopedic surgery, and a vascular surgeries. And there are few case reports about the GI surgery as well. So this is not a new topic, new for us because we never thought of. And so my presentation will focus how the long-term complication of the abdominal surgeries, including all organ, esophagus, liver, colorectal, and the liver transplant, bariatric surgery as a part, and gallbladder surgery, does their complication affect the long-term outcome? I will cover in this presentation. Although the definition of complication has very well covered by my previous speaker, but I want to reiterate that the complication means unexpected problems or adverse event that arise during or after the medical procedures or medical treatment or the illness. They can range from mild issues to major issues, including the organ failure or the sepsis, and complication to the point can be the surgical procedure related, like wound infection, bleeding, or anesthesia related complication. They may be medical treatment related also, like adverse drug reactions or prolonged hospital stay that may invite development of deep vein thrombosis or pulmonary embolism. And lastly, the chronic condition related. It means it's a patient related factors, maybe the cardiac disease, neurological disease, they may invite more complication in the post-op period. So I found this study, the landmark study, it is one of the first study, what I found in literature, that focuses on the long-term outcome after the complication. There's more than nearly 5-year outcomes. Other studies are presenting only 30 days outcome also. So this is the study, primarily observational cohort study of nearly 860 patients that covers the major abdominal surgery from esophagus to colorectum and conducted at the Amsterdam, Netherlands. The cases included over here were the patient who underwent the bowel resection. It means esophagectomy, gastrectomy, colectomy like that. And cholecystectomy was the not included in this surgery because they thought there is no bowel resection for this particular point. So they excluded the cholecystectomy for this presentation. They do classify the complication and they do include the benign and malignant disease for this. They do include the laparoscopic surgery and the open surgery for the assessment. And they divide the complication based on the Cleveland-Lindo classification, that is the most commonly accepted classification system. And they also made it easy for their analysis. They defined grade 1 and grade 2 as a 1 complication, as a minor complication, and the grade 3, 4, and 5 as a major complication. And if you see how type of surgery was done in this study, the upper GI surgery was making nearly 23% of the surgery. HPB surgery was nearly 12%, where the pancreatic liver resection, biliary duct resection was done. And thirdly, the colorectal surgeries that were making the most common component of the study part. And with the colectomy was done predominantly and followed by the rectal resection in this study. And the outcome was that the post-op complications were nearly 42%, but major complication, major means even grade 3, 4, 5 were the 24%. And the outcome was that the patient with minor complications was significantly older compared to patient without complications or the major complication. And second outcome was that patient who underwent the upper GI surgeries had significantly more complication compared to HBV and colorectal surgeries. In that 30 days follow-up, 11 patient has the mortality, and upper GI surgery patient had the anastomosis leak, mediastinitis, sepsis, they died because of that. In HPV surgery, they reported only one mortality. The patient had the aggressive nodal disease, they done aggressive vascular resection, nodal clearance. The patient had the post bleeding. Or in a colorectal surgery, they had anastomosis leak. Along with that, patient had deterioration of the existing cardiac and lung functions. The average follow-up was ranging the 1100 days. That makes nearly 6 years. The ranging from 36 days to 2300 days. The mean survival in a patient who had uncomplicated case was the nearly 1100 days. That is nearly 5 years. The patient who had the minor complication and their mean survival was 1500 days. And the patient who had the major complication, they had mean survival only the 1500 days. So that shows significant decrease in the overall survival of patient who had the complications. This is well displayed in this survival curve also. The patient with a colorectal uncomplicated, followed by the colorectal complicated disease, followed by number 2, the HPV, those had uncomplicated, they had a better survival, then followed by the HPV complicated cases, and third was the upper J uncomplicated, and last with the upper J complicated case. So the sequence of outcome they could analyze through this survival analysis. I also look the different perspective of the patient, like liver transplant patient, how does it happen in the patient. I could find only one study that also retrospective of 164 patient, and they said over 7 years, and their conclusion was like similar, as a complicated post-op care always influence not only the short-term survival, but also the long-term survival. Then I thought that this primary study excluded the gallbladder surgery. Is there any study assessing the impact of gallbladder surgery complication? I did not find any direct article carrying this title, but I could find one study that assesses the mortality after cholecystectomy. It's a population-based study of the Swedish registry. So I think we can discuss in a little bit. So this study shown the 30-day mortality of nearly 0.15%. And they found predictor of mortality were age more than 70 years, ASS scores high, patient underwent surgery for acute surgery, but later to part, open surgery and the presence of the post-op complications, they were predictor of the survival. So this study focused only the 30 days mortality, but here important what I could understand is that the patient who had the complication, they had the less survival. Would have been this study go for a long-term survival, they might replicate the outcome what previous studies shown in this. Regarding the bariatric surgery, does bariatric surgery complication really have a similar outcome? I didn't find any studies, but I could find that bariatric surgery given an overall survival benefit because of disease resolution, because of metabolic disease resolution, and also cancer-free survival. So far there is no literature reported about this subset of patient, but I think so in due course of time, we may find a similar outcome suggesting the bariatric surgery outcome, whether they really impact the survival or no. So what are the predictors for long-term survival in this patient? So patient those underwent the upper GI surgery, those with preoperative weight loss and having the positive lymph node, they have worse outcome. But good point is that those underwent the minimum invasive surgery, they have protective effect. Similarly, for the HPV patient, they divide in two parts. Gender basis also male patient and female patient. In the male patient, the 2 points were common: increasing age, weight loss, and the positive lymph node. They had a poor survival. In the female patient, they found that along with the weight loss, the patient who had the post-op complication, they have the poor survival. So this is one of the subset of patients. They found that these patients have the poor survival in a long-term time. And lastly, about the colorectal surgery patient, here the predictors were increasing age, ASA classification of higher grade, weight loss, and positive lymph node. Like usual, they have the poor survival. But here again, like upper GI surgery, the minimum invasive surgery had a protective effect for these patients. So what is the hypothesis why it is happened? So why it is the so researchers have given their own hypothesis. They said the patient who develops the post-op complication, whether it's infective complication or the non-infective complication, they usually found to have the sustained level of inflammatory markers in form of C-reactive protein and the procalcitonin. And this persistence of the inflammation that impacts the other organs, especially the heart and neurological dysfunction. So these they could propose. Regarding the cancer patient, what the cause? If they propose that there is surgical stress, activate the neuroendocrine and the immunological pathway that suppress the normal immune system. And because of that, there's a growth of residual malignant cells in a cancer patient. They also highlighted that the importance of stress following the surgery and adding with that critical illness in the patient, if patient develops sepsis or the patient requires the blood transfusion during the course of recovery, that further increase the cancer cell seedling in these patients. And of course, we all know any oncology patient underwent the surgery, if they develop the complication, the adjuvant therapy is delayed for some reason till he recovers from that. So all these factors are cumulative impact the low survival rate and disease-free survival. So points comes, can we improve it? Can we make it better? Yes. There are way has also been reported in the literature, that is the prediction of the complication early phase that can be done. The one of the study they show if do the CRP as a inflammatory marker is more than 140 on post of day 3. If you do a CT scan, we can find some complication, upcoming complication in these patients. The another study that made a prediction module and it's basically systemic review of the various studies, and they predict that if CRP less than 75, we can safely discharge this patient, and if CRP is more than 215, we should add the CT scan to find out the upcoming complications. So what are other studies we can have to minimize this complication? So first is we should have the risk assessment protocol that can predict the complication like we discussed now. Then the important common denominator I could find that there is a importance of surgical stress response. The physiological stress after the surgery, after the complication, if we can modify it, we can minimize these complications. And the important part that surgical techniques come as the foremost parameter, where there is a way should we have minimum tissue trauma. If you are using a minimal invasive surgical approach, that can also control the surgical stress. And the utility of, or I would say, incorporation of the ERS protocol in a day-to-day care of the patient, and the goal-directed therapy if patient had a sepsis, if managed by this philosophy, the outcome has already been proven that they improve the outcome. Now, there's a role upcoming of the robotics as a way to minimize more stress beyond the laparoscopy, and the technology, the AI coming as a predictor of the predicting some complication like for eye diseases. They have in the protocol where they predict the complication, eye surgery. So similarly, we can see the long term, this technology can be a useful tool for us. So in the conclusion, the post-op complication negatively affect the long-term survival in upper GI surgeries, female HB patient, and the gallstone surgeries. Minimal invasive surgery has a protective effect. For as a surgeon, our aim is should be to minimize the surgical stress by using meticulous surgery technique, use more of the laparoscopic technology, and the ARS and gold direct therapy for our patient if that are the complications. And if we should include the predictive model like CRP or CT scan for a early prediction of the complication, and still these are limited study I could find. We need a more study, more wide application of the marker to get a better insight on this topic. Thank you.
Wonderful talks. Both of you have completed the whole spectrum of this. But I'm a bit uncomfortable because when we talk about complications, we are talking about surgical complications from the time I take the knife in my hand. You've talked about stress, that is okay. So what happens if a patient comes to the theater, has a drip on one side, but you want it on the other hand, and the drip is changed on the other? The patient has stress. That is not included in. What about the errors? You have said that it ultimately affects the health of the patient. So errors, whether the patient has been postponed once and taken again, it doesn't count as a complication. We are not counting that as a complication. Patient is on table, on anesthesia, patient is claustrophobic, the anesthetist pushes the mask on the face, patient feels stressed. That induces a stress response to the patient, right? So all these things, I think, ultimately have to be included. If you don't want to call it complication, you want to call it error, but there is something which needs to be a patient-centric, like a questionnaire in the post-operative period, which is answered by the patient or the attendants. They will exactly tell you what psychological stress, what things could be improved. The patient goes into the theater, he's made nude, and it is very cold. The patient feels very cold. And so these things, I think, should be included in the whole spectrum, which will ultimately affect the health of it.
Most of these classifications and gradings, they say that need for intervention, need for blood transfusion, need for PCD, need for reoperation as a criterion. Now, you may intervene early, I may not intervene early. So I in principle disagree with this parameter being used for classification. That is the consequence. And that is one point, whether you'd like to comment. And Second is to Avinash, benign diseases, cholecystectomy, if there's a bile duct injury and its consequences would definitely affect the long-term survival and more importantly, the quality of life. And third, you said that use CRP and CT and other predictors. So does early diagnosis and treatment of a complication, does it decrease the long-term effect of complication?
So we do not have a perfect system for measuring complications. The intervention part was chosen because it was the easiest to do. So that is the reason why intervention was chosen. And another point is that if somebody is intervening early or somebody is intervening late, and if it doesn't change the outcome of the patient, then I would say that for all practical purposes, it is similar, because suppose you started antibiotics 3 days late, but still the antibiotic worked and patient recovered. Whether somebody started 3 days earlier and the patient recovered. So obviously the stress of the patient is more, maybe the hospital stay is more. So both in true sense they are not same, but for all comparison it should be same. And suppose because you started antibiotic late and then you had to do a pictorial drainage also, then obviously your complication is already increased, so that would take care of the delay in treatment. So and this part was intervention part was chosen because it is easier to document. So if you see a patient chart, you can easily find that what all antibiotics were added. So you don't have to look for the patient every time and go whether he has developed this complication or that. You just see the chart, treatment chart. If pigtail has been put, if patient has been operated, if oxygen is given, all these things will be there in chart, and then you would be able to know the status of the complication. So it is easier to do, but I would agree with you that it is not the perfect system.
Sir, regarding your query, I do agree for malignant disease, we know it is a malignant. They may, majority patient may, I would say, may not survive longer despite our best surgical approach, based adjuvant therapy. But the concern, what I had in my mind, they got benign disease. So this particular study, they excluded the gallbladder surgery patients. So looking for any study that documented about this, because I know through the AGPG experience with your all efforts we are doing on this subject, I didn't find any study had to look into this scenario for long term. We all know presence of complication improve and decreases survival, but I didn't find beyond the 30-day complication rate. I'm sure the way we start documented it, it may given some scenario that it affect not only quality of life, not only financial impact, not only social impact, but yes, overall survival also should go down. Thank you, sir.
Kindly just identify yourself.
Okay, I'm Luke Alishar from Tanzania. I wanted to ask that you mentioned that in Upper JSF there is an HPP surgery. One of the reasons for post-operative complications is lymph nodes. I wanted to know how does lymph nodes lead to post-operative complications? Is it because of the advancement of the disease? Is it because of the extensive dissection which takes place, or is it because of most of these patients they undergo preoperative radiotherapy? Maybe they can lead to these complications post-operatively. And about the classification of these post-operative complications, do we divide them into early and late complications? Because I think the reason for the early classification for the early post-operative complications within 30 days will be different from those which occur later in the time after operation. Thank you.
Regarding your query, I didn't find that type of discussion in the paper that I discussed right now. But I could see one case where, in the case of the underwent the pancreatic that and the nodal dissection, where they mentioned because the aggressive disease, nodal disease around that area, so they want to remove the complete nodal dissection. They done the periartery dissection as well. So there they could document it, that's the reason of the complication. For the upper GI, yes, we know usually disease in advanced stage, nodes are more aggressive disease, so biological disease may be advanced. And nodal presence, weight loss, they are otherwise also a good negative predictor of the less long-term survival. But how the comprehensive latent, I think more study will be required to put analysis on that, and then we come to a conclusion, yes, these are the exact cause for the patient compromising that.
Regarding your early,
Yes, I do agree. I think this paper has given eye-opening for me, for audience as well. So people sitting over there from working institutes, so at least we start looking at our own data. How does our results shows in that part?
I think Dr. Rajesh mentioned that saying this minimal invasive surgery has decreased the rate of complications. And for very obvious reason, common sense also tells. And as soon as there are lymph nodes and you have to do a dissection, it is obvious whichever way you use, the invasion will increase, and hence the the chances of complications are likely to be high, whichever procedure you adopt, open, laparoscopic or robotic, because the dissection extent of dissection increases, invasion increases.
And another thing with upper GI surgery is the involvement of the lungs. So if you're doing dissection in the lung hilums or near the nerves, so obviously you are more likely to get postoperative pulmonary complication, which can have a direct consequence on the postoperative outcome. So upper abdominal surgeries and upper GI surgeries usually will have more pulmonary complications.
Still working on the same pattern for last 20 years. If a patient has a complication following a lap chole, which is a major complication, is most disastrous than a patient who is having an advanced disease, malignancy, in which you are trying to do a resection. Because the family scenario, the long-term survival, everything gets affected. The quality of life gets affected. So we need to rethink into it that we can't just define everything as a blanket statement that Clavendino defines like this.
I'll have a counterpoint to this, sir. Clavin is not something that you identify that this is the complication. It is a means to do studies. So when you are comparing, say, 100 patients of lap chole, they are very homogeneous population. And if you want to use clavin in that kind of population, you can easily compare. But if you point out a scenario where, say, all the patients are having advanced malignancy and some patients are having, say, only simple laparoscopic surgery, obviously you can't use clavin complication to compare these patients. So clavin complication score is used when you have a homogeneous kind of a population, which usually would be in most of your RCTs. You try to make your population as homogeneous as possible. You take ASA 1 patients, ASA 2 patients, less than 70 years. So all those criteria, if you are using, then obviously the next best thing would be to use clavin.
I think
Exactly, that's what I want to say. That Clavendino is for a particular group. We want to compare within the group. Now, the discussion is a long-term survival following the surgeries with a complication. So the discussion was a lymph node disease. So you can't compare a periamputary carcinoma which has a T1 disease and undergoing a PD versus a T3 N2 which is undergoing a PD. You can't compare these two because they will have a different post-operative course.
Absolutely, sir. Absolutely.
Compare these two.
the medicine, particularly surgery and complications, it has a lot of philosophy involved into it. What Ajay told, that you see, if the expectation of the patient, the relatives, and everybody, and your own expectation out of his laparoscopic or robotic or open cholecystectomy for saying gallstone, symptomatic gallstone disease, and patient lands up with a complication of bile duct injury, you see the difference between the morale of everybody. वैसे base a patient whom you have already told, the relative patient knows, relative know that he has a second stage or third stage disease, where we are trying our best to give you the best chance of survival, and that survival has already been explained to the patient and relatives far too many times. So the philosophy is always, so we can't write a paper.
Tell my residents or students when taking a branch, GI surgery is the most catastrophic branch because the patient comes fit. He comes to you when he's absolutely fine. Doesn't know that he has to do a laparoscopy and can have complications. Vis-a-vis a patient who is undergoing a CABG, he knows the patient is already, he may not survive. A patient who is undergoing neurosurgery, they accept, but इस बच जाएगा तो बहुत अच्छा है. बचा लोगे डॉक्टर साहब तो बहुत अच्छा है. Same thing with onco surgery. They say cancer से बच जाएगा तो बहुत. GI surgery they don't say that. They say अच्छा है तो अच्छा जाना है. So your complication rate decides your future. So GI surgery is different from rest all the ones.
But there are two things in your session, like Dr. Rajesh spoke about how do we define complication, the simpler part of it. But sir has put up a mind-boggling question of whether it affects long-term survival. So you'll have to put it into subsets, and it's an area for way forward to learn about in different subset of patients. Whether a complication happen as simple as a leak, whether it affected with formation of adhesions, quality of life, and then the last and the more difficult question, whether it affects survival.
You see, these will always remain a matter of conjecture and debate. You see, complications, this survival, the quality of life. Now most of the people in you see, when we were poor, then we are only thinking of roti, kapda, and makan. When we have something, then we start thinking. So quality of life is a very important thing. And in a patient who has a cancer, he is not bothered about quality. He is more bothered about quantity. And a person who has a benign problem, which is much more rampant, he is bothered about the quality of life. So it will remain very staying. It will require, I don't know how long a study it will require to compare the long-term survival in each and every scenario. I think with this, no more discussions, and we come to the end of the first session. Thank you very much.